Good afternoon again, everyone. My name is Twin. I am Community Health Resource Center's Program Manager. Community Health Resource Center, or we also call it CHRC, provides 4 main areas of service to supplement your primary care. Those 4 areas of service that we specialize in are health education, like this, health screenings, behavioral health services, and medical nutrition counseling, which also includes guidance for inflammation and joint pain. So if you are interested in supplementing your joint pain management with informed diet choices, please make sure you take down my email on the screen here, and we can connect about how to get you an appointment with a registered dietitian of ours.
Okay. Hi, everyone. My name is Ishita Aggarwal, and thank you for that kind introduction, Twin. I'm happy to be discussing with you all today how a rheumatologist may approach investigating a patient who presents for joint pain. So a patient may present with joint pain in multiple joints, and if the pain originates from the joint, it is a true arthritis. However, this must be also distinguished from pain that arises from adjacent structures such as bone, tendons, or bursa. And sometimes there are other psychogenic factors or metabolic conditions that may mimic autoimmune arthritis, such as hypothyroidism. Once the arthritis is suspected, physicians should be able to distinguish between inflammatory forms of arthritis and non-inflammatory forms, some of which we will review today. So there are a number of factors that we use in the history and exam to distinguish joint pain. First, are the symptoms acute? What is the chronology of the symptoms? Are they acute, subacute, lasting about 2 weeks, or chronic? Acute symptoms may last for hours to 2 weeks, and symptoms are considered subacute to chronic after 2 weeks. The pattern of chronic symptoms should also be classified as intermittent or constant to help identify the behavior of the inflammatory process. Inflammation is suggested by the presence of joint swelling, redness, and prolonged morning stiffness and pain at rest. And on the other hand, weight bearing and movement may worsen the pain of non-inflammatory arthritis conditions such as osteoarthritis. The distribution and the pattern of joint involvement is also assessed by looking at the symmetry, number, and types of joints involved. And the size and kind of joints involved also serve as diagnostic clues. In conditions such as spondyloarthritis, which we will discuss, that often involves the spine and sacroiliac joints and medium to large joints, you may have involvement of shoulders, hips, knees, and ankles. Smaller joint involvement may be seen with the wrists, fingers, and toes in conditions such as rheumatoid arthritis and lupus. And extra-articular manifestations, so other symptoms that the patient may have beyond the joint, can help also narrow the diagnostic evaluation. Example of this are severely dry eyes, dry mouth, Raynaud's symptoms, oral ulcers, nasal ulcers, rashes, and weakness may help suggest some systemic inflammatory rheumatologic conditions. Other things such as weight loss, fever, night sweats are also common with systemic illnesses. So for example, the patient demographics and disease course also play a role in distinguishing joint pain. We may see, for example, a 50-year-old woman with symmetric progressive polyarticular, so more than 4 joints involved, joint swelling with prolonged morning stiffness, whose history may suggest a rheumatoid arthritis. However, this woman may develop something like a rash on the face and oral ulcers that may suggest lupus diagnosis. Alternatively, she may develop thickening of the skin, which would suggest another diagnosis such as scleroderma. Thus, a series of visits over time may be needed to arrive at a specific diagnosis in many patients with pain in multiple joints. So the cardinal signs of inflammation include redness, which is rubor, warmth, calor, swelling, tumor, tenderness, dolor, and loss of function, which is also called function lesa. Non-inflammatory arthritis can also present with swelling and tenderness, but does not typically cause redness or warmth. You may also have things like periarthritis in surrounding structures such as tendons, ligaments, and bursa, and this should be differentiated with a physical exam. So in terms of evaluation of joint pain, I've alluded to this, but we must make the distinction between inflammatory joint pain and non-inflammatory joint pain. So inflammatory joint pain is typically involving, you see a lot of redness, swelling, and warmth of the joints. It typically improves with activity, and there may be associated morning stiffness, usually lasting for more than an hour, where the person has difficulty moving their hands or other joints, difficulty making a fist, for example. Non-inflammatory joint pain, usually there is no redness or warmth, although they may still have some deformities and swelling. It typically is better with rest, and there's typically no prolonged morning stiffness. In terms of disease chronology, acute joint pain is pain that is defined as being self-limited and lasting for less than 6 weeks. Acute pain may be part of a self-limited disorder, or it may be the start of a chronic disease. Versus chronic polyarticular arthritis, so involving multiple joints, often develops gradually, but can present abruptly as well. Usually joint swelling and inflammation should be present for at least 6 weeks prior to diagnosis. So moving on, in terms of back pain, that's another part of the evaluation. So we also ask questions about inflammatory back pain versus non-inflammatory back pain. Non-inflammatory back pain is very common, occurring often with exertion or with manual labor. Typically is better with rest and without significant morning stiffness. Inflammatory back pain is usually worse at night and in the morning, often wakes up the person from sleep. And it generally gets better with activity and worse with rest, and is also associated with morning stiffness lasting more than an hour. In terms of evaluating for acute back pain or acute joint pain, there's a few basic evaluations that we can do. So we usually check for, normal cell counts and liver kidney function tests, thyroid tests. We may check muscle enzymes. We may check a chest x-ray depending on the symptoms that are reported and smoking history. Viruses can often cause an acute self-limited polyarthritis involving multiple joints, and the specific cause for viral arthritis is not always investigated. When you're suspecting inflammatory pain, we often check certain antibodies such as rheumatoid factor, CCP. We may check a uric acid to evaluate for gout, a genetic marker called HLA-B27, and some inflammatory markers called ESR and CRP. And based on the symptoms, we may check an ANA test. If it's applicable, and if we think that there's some history of potential viral infection, we may do some testing for viral etiologies such as EBV, parvovirus hepatitis, HIV, and depending on the history, we may screen for Lyme as well. Direct bacterial infections rarely cause polyarthritis, except for infection with gonorrhea. And classic reactive arthritis can be associated with enteric infections, so involving the gastrointestinal system, or with urogenital infections such as chlamydia. The evaluation may also include joint x-rays. So I wanted to start with talking about osteoarthritis, as it is the most common joint disease. And in primary osteoarthritis, there is no often predisposing factor that's apparent. There is a wearing down of the normal synovial cartilage. Osteoarthritis may occur of the interphalangeal joints, so of the joints that are in the middle of the hands, as well as the distal joint of the hands, and at the base of the thumb, and is more common in women than in men. During evaluation of the patient's joints and range of motion, we may feel kind of like a crunching sensation that's called crepitus, without warmth, and typically without redness. That suggests a degenerative type of process. So here in these images, you can see examples of osteoarthritis on patient images, as well as X-ray findings. The X-ray shows a very severe form of osteoarthritis with erosive changes. So there's some damage to the bones. And there are what we call Bouchard's nodes, that are the swelling of the PIP, proximal interphalangeal joints, and the distal interphalangeal joints, called Heberdine's nodes, that can lead to this joint deformity and inability to straighten the hands. This can lead to a destructive joint disease, but you see that there is sparing of the metacarpal joints, which are the knuckles on the back of the hand. The X-rays show these central erosions, loss of joint space, and certain other findings such as osteophytes or extra bone production that is suggestive of osteoarthritis. Age is the most powerful risk factor for osteoarthritis, but minor trauma and repetitive use are also risk factors. And there can be damage to the cartilage at the time of the injury and with use of the affected joint. And the normal cartilage can degenerate if the joint is unstable. We also see sometimes osteoarthritis with people with certain occupations with a lot of manual labor. So those who operate with jackhammers, for example, may get osteoarthritis in those joints due to repetitive use. And there are some hereditary risk factors as well in some cases. For example, mothers and sisters of women with osteoarthritis involving the distal joints are 2 to 3 times more likely to get osteoarthritis in these joints as women who are mothers and sisters of unaffected women. And certain genes also encoding proteins of the matrix of the cartilage and bone are also implicated in this, but there has not been any specific mutation identified for the most common forms of osteoarthritis. Certainly, obesity is a risk factor for knee and hand osteoarthritis, and obese people who have not yet developed osteoarthritis may be able to reduce their risk, and even a loss of 5 kilograms of weight can lead to a 50% reduction in the odds of developing symptomatic knee osteoarthritis. The joint pain described with osteoarthritis is typically a deep ache that's involved in the involved joint and can be aggravated with repetitive use of the joint and relief by rest. So next, we will move on to some images of knee osteoarthritis. You can see here that knee osteoarthritis may involve the medial compartment of the knee. I don't think you can see my pointer, but as it does here. So there is a loss of joint space in the medial compartment, or it can involve the lateral compartment or the patellofemoral compartment. You may have some joint swelling, effusions within the joint, but they're typically small with osteoarthritis. And with exam of the knee, you may feel some bony hypertrophy. So you may see some enlargement of the knee, and there may be some tenderness on the exam as well. So the treatment for osteoarthritis, the aim is really for palliative treatment and to reduce pain, maintain mobility, and to minimize disability. No pharmacologic agent has really been shown to prevent, delay the progression of, or reverse the pathologic changes of osteoarthritis. Some of the things that we try are for joint protection and analgesics that include Tylenol. So 30 to 40% may find Tylenol as effective as NSAIDs, such as which are the non-steroidal anti-inflammatory drugs such as Advil, Aleve, ibuprofen, naproxen. COX-2 inhibitors such as Celebrex may be used. And Cymbalta, which is a agent in the SNRI category, has an effect on the pain pathways, and there's no long-term studies on this, but it may reduce pain specifically for knee osteoarthritis. Splinting may be used for some people with hand osteoarthritis, specifically of the carpal metacarpal joint here. And you may see that, if there is unilateral, so one-sided involvement of the hip or the knee, using a cane in the opposite hand may actually help to reduce joint pain by reducing the joint contact force. So that may be another strategy to help. We typically recommend to strengthen the muscle around the affected joint with physical therapy and aerobic conditioning, and that can help to protect the joint. Sometimes patients find some benefit with certain supplements such as glucosamine or chondroitin. We do some intra-articular joint injections, typically with steroids, that may help to provide symptomatic relief for a few weeks to months. However, this is not typically recommended on an ongoing basis, as chronic use of intra-articular injections, so within the joint injections, may actually damage the cartilage. So they should not be repeated more than every 4 to 6 months. Some people do try intra-articular hyaluron injections that have been approved for knee osteoarthritis, but they have not really shown superiority over using things such as the non-steroidal drugs and the NSAID category, and there's no real efficacy of those shown, to use viscosupplementation over placebo in randomized trials. Topical therapies may be beneficial in osteoarthritis, especially in those who are unable to take some of these other drugs, such as the NSAID category, due to other comorbid conditions. So Voltaren gel or capsaicin cream may be helpful in those situations. And then ultimately, if there is a lot of loss of function of the joint, joint replacement is considered if the medical management has not been sufficient. So we will move on to talk a little bit about rheumatoid arthritis. So rheumatoid arthritis is characterized by an inflammatory polyarthritis, so involvement of multiple joints with swelling and tenderness, particularly in the hands and feet in a symmetric distribution. Most people feel joint stiffness for more than an hour in the morning, and that is part of the inflammatory arthritis characterization. There can be certain antibodies associated with rheumatoid arthritis, specifically the rheumatoid factor, which is a little bit less specific, but type of immunoglobulin that also can be detected with chronic infections, endocarditis, so infection of the heart valves, or in other autoimmune disorders. Anti-CCP antibody is a little bit more specific for rheumatoid arthritis and can correlate with erosive disease, so more damaging and severe rheumatoid arthritis. In the clinical setting of having symmetric involvement of multiple joints with swelling, a high level of rheumatoid factor antibody is associated with poorer outcomes and a higher predictive value for diagnosis of rheumatoid arthritis. So in this picture, you see the hands of a patient with severe rheumatoid arthritis. You can see that there is swelling and involvement of the joints of the MCPs, so the joints over the knuckles of the back of the hand. And you can also see what we call swan neck deformities. So there's typical involvement of some of the other joints, and also some wrist swelling, particularly of the right wrist. Here you can see a picture of a rheumatoid nodule, and rheumatoid nodules are seen in about 20% of patients with RA. This is basically a massive inflammatory tissue with a central area of necrosis or collection of chronic inflammatory cells and inflammation surrounding those cells. Rheumatoid nodules can occur over extensor surfaces and joints, so like around the elbow, and at sites of chronic mechanical irritation, such as the toe and the heel, as well as around the subcutaneous tissues of the fingers. So here is basically the 2010 ACR-EULAR classification criteria for rheumatoid arthritis. It may be more information than you need. Classification criteria are developed for inclusion in research studies, but they are helpful to kind of look at as guidelines for diagnosis, but they do not themselves make a diagnosis. A score of at least 6 is needed for classification of patient having definite rheumatoid arthritis. So who are the patients that we should test for this? Those that have at least one joint with swelling and where the joint swelling and pain is not better explained by another disease. Like I mentioned, a score of at least 6 is needed for classification. So we look at the pattern of joint involvement and the number of joints that are involved. The lab work, looking at the autoantibodies that may be positive, so rheumatoid factor and the CCP antibody, and how high are those antibody levels. And then we also look at certain inflammatory markers, the sedimentation rate and the CRP, and we also assess for duration of symptoms. So have they been there for less than 6 weeks or 6 weeks or greater? Having increasing joint involvement and involvement of the small joints gives you an increased weighted score, and there's higher points for high positive rheumatoid factor or CCP. And having ESR CRP also gives you 1 point. So to briefly touch on the treatment for rheumatoid arthritis, so the prognosis and the outcome are improved when the therapies are started early, and there's better prognosis within weeks or months of onset with the initiation of what we call a DMARD, disease-modifying agent. Steroids can relieve short-term symptoms and signs, and we may often use them initially as we are starting patients on the chronic long-term treatments. And conventional DMARDs are methotrexate, hydroxychloroquine, leflunomide, and sulfasalazine, all of which are pills. Methotrexate can also be subcutaneous injection. And then we have many options these days for biologic treatments. So there are many different categories, as you can see listed here, of drugs in these categories. And we we balance the patient's other comorbidities, other medical conditions, and what may work in terms of oral agent versus infusion versus injection in order to choose therapy. So we see that once we start therapy early, then there is less progression of rheumatoid arthritis activity the earlier we start. I will now move on to talk a little bit about a different category of inflammatory arthritis called spondyloarthritis. And this involves a few different conditions. So with spinal involvement, you can have something called ankylosing spondylitis. This can involve the vertebrae, or it can involve the sacroiliac joint, leading to something called sacroiliitis. You may also have peripheral joint involvement, and you will see this in reactive arthritis, psoriatic arthritis. And you may have involvement of the entheses, which is where the tendon meets the bone, and inflammation of the entheses. Or you may have dactylitis, which is also like a severe sausage finger appearance of finger or toe. Some of the other associated symptoms you may see with spondyloarthropathies include inflammatory bowel disease, a history of inflammation of the eye, so uveitis or scleritis, psoriasis involving the skin or the nails, urethritis and balanitis may also be associated. So just to see, some of these that we just talked about. So in the top left picture, you can see, picture of a psoriatic plaque. Here is the second picture of anterior uveitis, with a red painful eye, significant inflammation. This has to be evaluated with the ophthalmology. And then patient might have inflammatory bowel disease that goes along with this group of conditions. On the top right, you can see a picture of inflammation of the Achilles tendons. So this is a type of enthesitis, which can be seen in these conditions. On the bottom left, and you can see that there are some fingers that are diffusely swollen, so that may be seen in psoriatic arthritis. And you can also see like diffusely swollen toe, like the right fourth toe in this picture, that we may call dactylitis, and can be seen in these conditions. This is a picture of a 48-year-old gentleman with history of ankylosing spondylitis, and you can see that he is unable to fully straighten his spine. So he has this kyphosis, basically curvature of the spine, with restricted range of motion in the cervical spine. So on his x-ray, there's actually this extra bone formation called syndesmophytes, which bridge the adjacent vertebrae throughout the spine. And this is very characteristic of the spinal involvement seen with ankylosing spondylitis. Here are some more pictures of psoriatic arthritis. So we can again see that toe involvement called dactylitis, and you see a lot of also involvement with the skin, psoriasis, as well as the nails. So here you can see that the sausage shape of the toes is caused by soft tissue swelling, and it's seen much more with psoriatic arthritis rather than in things like rheumatoid arthritis. In the second picture, you can see that this patient has a very symmetric involvement of multiple joints that involves the distal joint, as well as nail changes that are characteristic of psoriatic arthritis. And then in the bottom picture, you can see that this patient was started on biologic TNF inhibitor therapy, and there is significant improvement in the skin and nail changes, as well as the swelling at the distal joints. So moving along, this is a picture of gout, and you may have heard of gout or have family members that have been affected by gout. And gout refers to a disease that happens in response to the deposition of crystals called monosodium urate crystals that can deposit in the joints, the bones, and the soft tissues. And it can cause an acute inflammatory arthritis, or it can also lead to a chronic arthritis once there have been multiple episodes. And it can cause these deposits of crystals under the skin that you can see in this picture, called tovai. Very commonly and classically, gout affects the big toe, and that is called podagra. And if that happens, that's very, you have a very red, hot, swollen big toe, which is very classic for gout presentation. And this happens when there's too much uric acid in the blood. Uric acid is produced when the body breaks down certain foods, and there are multiple modifiable risk factors and non-modifiable risk factors for gout. The non-modifiable risk factors include male gender, advanced age, and ethnicity. For example, this is seen much more commonly in Pacific Islanders. There are more than 200 genetic loci that have been identified to be associated with high uric acid levels. The modifiable risk factors include obesity, beer, sodas, fruit juices, foods that are high in containing fructose or sucrose, having a history of hypertension, diuretics, chronic kidney disease, post-transplant, and the use of certain medications like cyclosporine. Gout flares, which are attacks of severe pain involving multiple joints, it can involve big toe, ankle, knee, joint, or joints of the hands, elbows, where the joints are very hot and swollen, and more than one joint may be affected at a time. Gout flares tend to occur more commonly at night. We diagnose gout typically by removing joint fluid if there is a very swollen joint and demonstrating the presence of these uric acid crystals under the microscope. In most patients with gout, the uric acid level is also elevated during the episodes where the patient is not having any gout flares, although during an acute gout attack, the uric acid level may be low. So we measure the uric acid every 3 to 6 months, and we do this in order to monitor the response to urate lowering therapy. And the goal is usually to keep the uric acid below 6. This next slide shows a picture of gout crystals under the microscope. So these are what we call birefringent needle-shaped crystals under a light microscopy. Treatment for gout. So there's treatment for both the acute attack as well as for preventive treatments. So gout, when there's an acute attack, you may use something like an NSAID, such as indomethacin. We may use colchicine. We may use steroids that are oral or injected directly into the joint. And in rare cases, use anakinra, which is a type of biologic. In order to prevent gout attacks, we typically start patients on allopurinol, and there are certain indications, for why we may start somebody on preventive gout treatment. Oftentimes, if there's only been one gout attack, we don't, typically start preventive treatment at that time. Usually, if there's been 2 attacks or more per year, there's any history of chronic kidney disease or kidney stones related to uric acid, those may be some reasons that we start this treatment. An alternative is febuxostat, with the other name being Uloric. And so both of these medicines help to reduce the uric acid level chronically. Other options include probenecid and pegloticase. Pegloticase is an infusion medication. And then we always counsel patients on weight loss and using a low purine diet, which involves avoiding alcohol, foods containing high fructose corn syrup, red meats, and shellfish, because all of these foods can increase the uric acid level and can contribute to a gout flare. Sometimes when patients have had a gout flare, it's, you ask about this history and they've often had one of these kind of foods just prior to the flare. So that dietary control is a very important part of the gout management. And then lastly, I just wanted to end with this last condition called pseudogout, which is kind of like a cousin of gout. There's just a different type of crystal that is deposited called calcium pyrophosphate crystal, and it can be deposited in the connective tissues. It may cause an acute inflammatory arthritis or a chronic inflammatory arthritis that leads to degenerative changes. And you may see calcification in certain areas on the x-rays, often involving the knees or the wrist. Other names for this include chondrocalcinosis and pyrophosphate arthropathy. Sometimes we do x-rays for other reasons and see, deposition of these crystals on the x-rays, but the patient may not be symptomatic from this. In other cases, some people experience significant joint swelling and joint pain that resembles like a gout attack. This condition affects about 4 to 7% of adults in Europe and the US, and especially among older population, and majority are asymptomatic. Things such as trauma, surgery, or severe medical illnesses can also provoke acute attacks. Pseudogout can actually present similarly to rheumatoid arthritis and is sometimes called pseudo-RA. Inflammation may occur in multiple joints in a very symmetric pattern, can last up to several months. And a chronic form of this condition occurs in 5% or less of patients. You may also see osteoarthritis coexisting with CPPD or pseudogout. Here you can see this rhomboid crystal on the electron microscopy that has been taken from joint fluid with somebody with pseudogout. There are some associated conditions with pseudogout, and we may screen for these, especially if the patient is younger or if there's some familial history of the condition. So things like hemochromatosis, hyperparathyroidism, and then certain metabolic conditions with low magnesium, low phosphate, and familial hypocalciuric hypercalcemia may be associated with pseudogout. So that is essentially, a brief summary of multiple conditions that we evaluate for when we investigate a patient with joint pain, and the approach that we take. Of course, there are some other conditions that can cause joint pain that I did not review today, such as lupus, scleroderma, and some of our other connective tissue diseases. But this is, kind of an overview of some of these conditions, and I'll be happy to take some questions.
Thanks so much. We do have a lot of questions that came in with the registration process. Right now we have 13. Some of them overlap, and I think that we can perhaps answer it all at once in a way. Let's see. So this first question, how does diet affect arthritis?
So that's a very good question, and I think it's a very open question in the field of inflammatory arthritis and rheumatology. We know that the microbiome in the gut does play a huge role in whether there are certain cytokines and inflammatory markers triggered that may cause some of the inflammation as seen with like rheumatoid arthritis or psoriatic arthritis. However, we don't really have, specific things that we know, like certain foods that, causing higher propensity for an inflammatory arthritis. The main thing that we do know more about is with gout. Like I mentioned, certain foods can trigger a high purine load in the blood and can trigger gout attacks. But for some of these other conditions like rheumatoid arthritis and psoriatic arthritis, we don't, that's still an open question that's being researched.
And on the topic of diet, there's another question that asks, does a low carb / gluten-free diet help with arthritis?
Some people do report that they have some gluten insensitivity, or with diet that is high in carbohydrates and sugars especially can cause more inflammation in their joints. So if that's the case, that can be, I encourage my patients to try and see, if trying to reduce their carbohydrate intake and reducing the amount of like processed sugars, would help to reduce some of their joint inflammation. And some people report that it does help. Again, there's not a lot of like official guidance about this, but some patients do find that to be beneficial.
All right, the next question is specifically about calcium pills. Does taking a lot of calcium pills ease joint pain?
Not necessarily. And like I mentioned, joint pain can be from multiple different reasons. But no, calcium is important for bone health and to help, prevent osteoporosis and loss of bone density. So it is definitely a building block for your bone, but does not necessarily help to alleviate joint pain.
Got it. Thank you. Next question is more of a personal question from this person. I have a lifetime's worth of wear and tear from sports injuries that I've recovered from. How can I slow deterioration?
So a lot of times we see that, people with sports injuries develop secondary like osteoarthritis in those joints. So anything that you can do to help strengthen the muscles around the joints, that will be really beneficial to protect the joints for the future. And specifically losing weight can help to protect the knee and ankle joints because of gravity, we place a lot of our pressure into those joints. And so, anything that we can do to continue to stay active and to, work on like weight management, and then as well as physical therapy to protect the joints and strengthen the muscles around the joints is usually what I recommend.
Thank you. Next question. What are some effective topical pain relief and effective dietary alterations to minimize joint pain? So I know that that's also a diet question that we previously addressed, but perhaps we can also specifically talk about the topical pain relief.
Sure. So there are a number of topical options to help with joint pain. Some of them are like available as patches, like Salonpas patches or lidocaine patches that are analgesic. And you may find the Salonpas patches even over the counter. Other topical things we recommend are like capsaicin cream, which can have a little bit of burning quality because it's basically like from these peppers. But some people find that to be very helpful for an analgesic. We also use topical non-steroidal creams such as diclofenac gel that can be effective. So those are some options.
Thank you for that. The next question. Joints on my fingers are swollen and sometimes they hurt. What can I do about it?
So yeah, I see like a couple of different people asking kind of similar questions. Somebody else also said my hands and fingers feel stiff and there's pain. Is this arthritis? So hand joint pain can be, like I mentioned, seen in multiple things. It's very hard to answer your question without being able to physically see and get some more of that history. Like I mentioned, the duration of pain, has there been swelling, is there associated skin rashes, and the pattern of joints that are involved. So that it's hard to know, just with limited information, whether that's osteoarthritis or an inflammatory arthritis or one of these crystal arthritides that can also affect the joints of the hands. I think next steps are really to just get that evaluated you can start with your primary doctor, and then if needed you can always see rheumatology for further evaluation.
Thank you. So I will check the question about is this arthritis? I'll check that one then.
Something else that may also be beneficial is occupational therapy, specifically like for hand arthritis, can be very helpful.
Okay. All right. The next question, I have psoriasis. Will I eventually develop psoriatic arthritis?
Yeah, sure. So it's much more common that people have psoriasis than psoriatic arthritis. Sometimes only about 30 to 40% of patients who have psoriasis develop a psoriatic arthritis. So definitely not, everybody with psoriasis develops an arthritis related to that.
Making great time here. If I get flare-ups of joint pain at times, how can I maintain activities such as heavy weightlifting and skiing?
So if there are times when there is a flare of joint pain, then I would recommend to minimize things like heavy weightlifting or activities that can further exacerbate the joint pain. Skiing as well is like a very strenuous type of physical activity. So probably that will exacerbate the joint pain. So you know your body best, and I think you have to evaluate if those kind of activities are going to exacerbate it, and if so, then I would probably hold off until your joint pain is feeling a little bit better.
Perhaps you can also help us define this acronym here, JIA in teens. It relates to the next question about how to manage without drugs if possible, and what are side effects or risks of medications such as Humira, if I'm saying that correctly.
Yeah, sure. So JIA is juvenile idiopathic arthritis, and it basically refers to an inflammatory arthritis that's seen in children and can look like rheumatoid arthritis, or it can look like one of these spondyloarthritis conditions, like I mentioned. There is quite a range in which this can present in children. And typically in kids, it is managed initially with non-steroidal anti-inflammatory drugs. However, sometimes that is not sufficient. Some people need the use of steroids or other biologics, such as Humira. There's, the other medications I mentioned for rheumatoid arthritis, such as hydroxychloroquine and sulfasalazine. Those may be considerations as well. So I'm not a pediatric rheumatologist. I don't have much guidance beside that in terms of like how to manage without drugs. It just depends on the frequency of symptoms. Sometimes patients have a lot of symptoms when they're children, and then it kind of burns out and they don't develop like a chronic inflammatory arthritis as adults. But sometimes they require like lifelong management and treatment. In terms of medications such as Humira, so Humira is like a TNF antagonist, and it's a biologic drug that's an injectable drug. With all of the biologics, there is some increased risk of infections. So that can be any type of infection, like viral infections, like the flu or cold, bacterial pneumonia, skin infections, urine infections. That's usually the most common. If there's been any exposure to tuberculosis or hepatitis, there's potential for reactivation of those. And then the other potential side effects in rare cases can be associated with demyelinating conditions such as MS, heart failure. Some people get like a drug-induced lupus. So there are some other risk factors that need to be discussed with your provider.
Thank you. This next question talks about a person's debilitating pain that comes and goes in their joints, lasting about a day or two. So again, that can be from many different things. There are forms of rheumatoid arthritis that have very severe joint pain lasting a few days and then it goes away. So this is called palindromic rheumatism, but it can also be osteoarthritis. It can be pain that's around the joints, and maybe you're perceiving it as pain in the joints, but can be from other things as well, like tendon issue or like bursitis. So I would need more information and evaluation to answer your question. Thanks for doing your best for some of these. I know that you're trying your best with as little context as possible. We have one last question from the Q&A, and we have another question that came in from the chat, but I'll just read off the one in the Q&A here. How do I get rid of the rattling in my knees and also knee aches? Again, I think that you'll have to do your best with the given context. Thank you for trying.
Yeah, so yeah, I mean, knee osteoarthritis is very common. It sounds like, maybe you have knee osteoarthritis, or sometimes people describe like a crunching or rattling sensation in the knee, which may or may not be associated with degenerative changes. Sometimes we just hear like cracking, popping of the joints, but there is not really an associated arthritis. If this is like knee osteoarthritis, then things that you can do to strengthen the quadricep muscles. So any kind of physical therapy and exercises you can do to, like squats and quadricep strengthening exercises is what I recommend. And you may need like formal consultation with physical therapists to kind of help learn some of those exercises. And then weight loss can also really help to reduce the pressure that is being put on the knees as well.
Sarah asks, or lets us know, I am hesitant to take my meds, prescribed or OTC, on a regular basis. I only take when my pain is the worst. Would it be harmful to me to take on a more regular basis to help control the pain?
Yeah, so again, like depends on what your pain is due to. So if you have like an osteoarthritis and you are taking, something like Tylenol or ibuprofen to help control the pain when it's the worst, then certainly that's okay. It's, helping more for pain relief. And there's like, appropriate dosing, like you can take a max of certain amount of the medication that, in a safe way, and that will depend on your other medical conditions. But if you have like an inflammatory arthritis, like a rheumatoid arthritis or something, like psoriatic arthritis, then having uncontrolled joint inflammation can cause chronic damage to the joint. So that requires kind of regular treatment to prevent ongoing joint damage.
Thank you, Dr. Aggarwal. Thank you. Oh, it looks like we have someone who wants to talk. All right, Nancy, go ahead. You can unmute yourself.
Thank you. This has been so valuable. My question is, what about yoga, gentle yoga and stretching for people who have OA?
Yeah, I definitely think yoga is a great exercise to protect your joints, strengthen your muscles. It helps with improving stability around the joints and core stability. So I think yoga is a great exercise for that.
Terrific. We offer that at the Women's Health Resource Center.
Great. Yeah, that's
Yes.
a great resource.
It is. Thank you.
Definitely. And not to be a competitor because we're only having one of these, but April 1st and 2nd, CHRC is also hosting a coincidentally same name, gentle yoga series. It's 1 hour each, and we're having it back to back. So you can choose one to go to or both, but it's led by a nurse, Lisa Marie Ampo, and she is will be doing a meeting format, not a webinar format. So you'll definitely be able to see the presenter and other participants so that we can all have an eye on each other and have a great discussion from that. So please look out. I will mention the registration link for gentle yoga in an email coming out too. But please note that the Women's Health Resource Center also does gentle yoga. Thank you for that, Nancy.
Yes, my pleasure. And I teach it actually.
Oh, fantastic.
Yes, I teach adaptive yoga for arthritis at the Women's Health Center.
Perfect.
And yes, so it's
a
lovely class.
Would you like to share a link or anything? You can feel free to email me so that participants in this registration can have that as a resource.
That's great. Perfect. I'd be very happy to.
Perfect. Thank you so much, Nancy.
Pleasure.
That is great. All right. So if there are no more questions or anything else that anyone would like to share, I will go ahead and end the meeting here. All right. Well, thank you, everyone. Have a wonderful afternoon.